my name is Savannah Seay. This is my Level 1C Fieldwork Reflection video assignment. I was placed at Talk to Me Therapy in Madison. It's an outpatient pediatric center. My clinical instructors were Sierra Sadler, she's a CODA, and Laura Vetter, she's an OTR. And we'll just get straight into it. So question number 1, professional communication, is describe a situation during fieldwork where you demonstrated professional communication with clients, supervisors, or staff. What strategies helped you be effective? So the main example that I could come up with were my parent reports. Strategies that helped me be successful in that were using the highlights of the intervention with the parents, highlighting what the child did good, and really just using a Big Mac approach. For example, one child did really well with his joint attention, but we still need to continue to facilitate that tripod grasp when we are holding a pen, a pencil, a crayon. But overall, his participation was good. He was interacting, he was imitating. Socially, he's doing a good job. And then questions regarding interventions, using that professional communication of just having that open mindset of like, hey, here's my idea, and do you have any suggestions? Do you have any hesitations? Like, what's some feedback that you have for me? Question 2 is critical thinking and problem solving. Share an example of a time you used logical thinking, critical analysis, or creativity to address a client need or assist in an activity. So with one of the clients, she has some trouble with balancing, and her proprioception is not the greatest, so her body awareness. But one of her goals was to participate in an obstacle course. So I had planned an obstacle course, set it up with balance boards and the balance beam, just to make sure that she was safe in a controlled environment, and I provided assistance as needed. But as we were going through the obstacle course, she began to add her own elements in there, and I let her do her thing. Just because her joint attention and her overall attention to task was also a goal. Being flexible and being creative and thinking logically about, okay, what goals can this address, because I don't necessarily want to pull her from an activity if she is initiating and she is participating, and also interacting with me during that. Next question is adaptation and safety. Describe a time you adapted an intervention method for a client. How did you ensure safety precautions were followed? For one of my sessions, I made duct tape wallets with a little boy. And because we were using safety scissors, they were a little bit difficult to cut through the duct tape. They were hard to manage. And so due to the difficulty, his safety awareness decreased. So I was having to give max verbal cues of, hey, let's slow down. Hey, let's slow down. Let's get your fingers out of the way. So then I ended up just doing all of the cutting parts for him, or I would start it and have him tear the tape instead, because fine motor was a big focus for him, as well as attention to task. And we used hand sanitizer before, just to make sure that no infection was spread. But that was a good one for safety and adaptation, of that intervention. Another example of an adaptation would have been, we played a hockey game in prone extension with a little pool noodle and a ball, hitting it back and forth. And if the child was unable to go into full prone extension, which we called Superman, we would have them go in a half Superman and just hold their elbows up and their feet could be on the floor. Next question is documentation and communication. Reflect on any documentation you completed or observed. How did it contribute to accountability, reimbursement requirements, and professional communication within the site? When documenting that previous intervention of a half Superman, we would say half Superman for specifics. when we were referring to prone extension, just so that way the next therapist was able to understand, okay, this is how this task had to be modified last time. Let's see if we can try it. But then that way they knew what was going on and how the task was modified. In our O section of our documentation, we would put the OT related skills that we worked on. So for example, gravitational security, bilateral coordination, fine motor strengthening, things of that sort. So that way insurance is able to see, okay, these are the exact things that they were working on in this intervention. Also, the exact times of the treatment session were put into the documentation. We used the CPT codes and made sure to write down how many units each session was worth. And then in our P, we would put our plan for the next session. That's also for if another therapist were to see them, to see kind of what the original therapist had planned for the next time. And then also anything specific to that client, for example, with preferences like crafts and things that they really don't like. They were write on a sticky note and put it into the chart, just so that way if they were gone one day, another therapist kind of can get to know the child outside of the evaluation and the session. Next question is use of professional literature. Describe an example where your supervisor used professional literature to guide intervention planning. How might you apply this in future practice? So one of the charts that we read had a diagnosis of TOC, and that is something that was really unfamiliar for us. And as we did further research, we found that OCD translate to TOC in Spanish. I don't want to say a majority, but lots of our patients came from Spanish-speaking households. So just really understanding that some diagnoses may be a little bit different within translation. So I definitely will be researching translated diagnoses and making myself kind of a cheat sheet moving forward. And then we also looked over the reflex integration resources for reflex concerns, just to sharpen our knowledge and get ideas for what to do during that intervention. And I'm sure that I will always do that, because that is always something that is super important. Next question. Ethics and professional guidelines. Explain how you saw the AOTA Code of Ethics, core values, or the guide to occupational therapy practice applied in your fieldwork setting. The main thing that I saw was advocacy. And the specific example that I have, I didn't write it, but my CI was writing an LMN to insurance for a cubby bed and providing parent education on why this is useful, so when they're talking to insurance as well, they're able to give the same clinical reasoning just from a parent standpoint. But the parent education was mainly a form of advocacy for the children, in forms of validating their child who is unable to communicate effectively, understanding those behaviors, understanding those sounds, and validating, oh, I understand that you're frustrated, I understand that you're mad right now, but the answer is no, that is not a choice right now. To help that child feel understood and possibly implement those emotional regulation strategies that we were discussing. And each intervention that was planned and implemented in the facility was based on function. It wasn't based on functional limits. It wasn't based on norms. It was based on each individual child's function, and I feel like that is exactly what occupational therapy is. Next question is cultural sensitivity. Share a time you demonstrated awareness and sensitivity toward a client's culture or abilities. What did you learn from the experience? Like I said, many of the children came from Spanish-speaking households, so being able to use that, like Amaria for yellow, zapatos for shoes, and using those Spanish words along with English as much as possible to facilitate that trust, build rapport with the child, and just increase that probability of effective communication within your session. That is something that was super, super, super important for us. And then as far as being sensitive towards a child's abilities, using that half Superman instead of a full. If they were not able to hold their feet up at the same time, we could still do that activity, especially if they were having fun in a half Superman, because that would be perfectly fine. It's still addressing all the things, and it is still strengthening that core, which is something that they will need to get to that full prone extension. There were so many situations with cultural and ability-oriented sensitivity that it would take so long to get through, but there were many situations, and overall I just learned to really check out that evaluation, check out that the psychosocial factors, the socioeconomic factors. Many of these children came from homes with parents that experienced substance abuse. Many of these children, their grandparents would bring them to therapy because their parents were in denial that something is wrong. So just being sensitive to that and understanding and trying to get down on the level of the child, because they might not understand, but we can. And the last question is mental health and psychosocial factors. Describe an observation or interaction where mental health or psychosocial behaviors affected a client's occupational performance. How was this addressed? So there was one little girl that we had. She was very upset Monday whenever she came in because she was not picked for her school parade. And with further talking with my CI, who is normally her treating therapist, her emotional regulation has really begun to creep in on her daily life performance. Anything that doesn't go her way, it takes an extremely long time to get her back calm and able to interact with the world in the way that she was before she got upset. So within the session on Monday, we did our emotional regulation strategies at the very beginning. Lots of sensory input, lots of breathing techniques, and we spent probably, I want to say, 5 to 10 minutes doing those emotional regulation strategies just to get her back to baseline so we could do therapy for the day. And then especially with our children who have a hard time with communication, whether that's due to a language barrier or just being nonverbal, they would become frustrated with attempts to communicate. So if they did not like something, they would start screaming or flailing their body on the floor. So validating that emotion and saying, I understand that you're upset right now. I understand that makes you really mad. What can we do to calm our body down? And then implementing those emotional regulation strategies in that session, but also educating the caregiver on how to handle those situations, validating that communication block and saying, hey, I understand that this is what you want, or I understand that this is how you feel right now, and that goes a very, very long way. But overall, this fieldwork experience was very awesome. I learned a lot. Once again, my name is Savannah Seay. I was at Talk to Me Therapy in Madison, and I had a great time. So thank you for watching. Bye.